Yeah, let's go to the next speaker, and let's take a look in the north. Our next speaker is Kevin Lafferty, a Scotsman. He is the National Policy Advisor for Access, Health and Recreation in Scottish Forestry, and managed there, among other things, the Woods for Health program. As with the speakers before, the aim of this program is to do something for mental health and to reduce the costs in the health system because of prevention. Mr. Lafferty, the floor is yours.
Well, good morning, everybody. It's a privilege to be here. I'd like to thank Selvans for inviting me to share with you some of the research from Scotland. I've got a short period to cover some of the research, so I just wanted to start by saying that we've been doing a lot of work in Scotland to bring the environment and the health sector together for over 10 years. These are just two pieces of research. But a lot of our learning has been about actually how do we connect environment and health professionals? How do we understand each other's language and structures and processes? How do health professionals work? And how do environment professionals work? The type of language and acronyms that we use. And my background is mixed. I started working in public health. I spent 12 years working in public health and health promotion, and then I switched to work in the environment sector, working for Forestry Commission in Scotland for the last 13 years. And one of my key observations is that we have to have more movement between both sectors. We need more professionals to spend time, environment professionals to spend time working with the health sector, and we need health professionals to come and be embedded with us within the environment sector. So a quick example of that would be we've had a public health consultant based within our department before. We've had trainee assistant psychologists and psychiatrists, and also we've had foresters and environment professionals spend time in the health service. So I'm not sure if other countries are doing that, but I think it's been really beneficial for us to do that and to learn a bit more about each other. There's more and more evidence telling us that we should be connecting health and environment, policy and practice, but what we do see is that there's still an implementation deficit. So I don't think we need much more evidence. I think we need more action and more change on the ground. When I'm asked by health professionals about the evidence, my reply to them is there is enough evidence, there is more than enough evidence for action. If you look at the requirements, and when you ask health professionals, they accept that the evidence base is there, that we need to have more change. Okay, and one of the things I want to talk about is a whole system change. What we have in the UK is still a national illness service, as opposed to a national wellness service. And I think forest medicine is part of the solution for a national wellness service. And the idea of taking an upstream approach to prevent people being ill in the first place. Okay, so it's about breaking down cultural and attitudinal barriers, and it's about shared investment and ownership. But an important point to make before I move on is that the terminology is really important. When people back home in Scotland and in the United Kingdom use the term forest bathing, they think this is going out to have a bath, to wash yourself in water with soap in the forest. It's not, the terminology doesn't work for us. So we use ecotherapy or forest immersion, this idea of immersing yourself. So I think having a standardized terminology would help. And also it helps in terms of different cultural understandings of these words. Okay, I'm not sure how many of you have actually been to Scotland. It's a small country, but it's extremely beautiful. A beautiful place to visit. We have a really varied topography and landscape. But lots of our people in our towns and cities are not visiting or using these outdoor spaces. They're not using them enough. And what we're trying to do is to connect more people with these spaces on a regular basis. And it's not about the once-a-month journey to the national park or the national nature reserve. This is about what we do every day. The places that are on your doorstep, the green and blue spaces that you can play in as a child, where you walk your dog and where you go for a run or a cycle. So it's about connecting the places, connecting people where they live and where they work. Now, over 10 years ago, we wrote this strategy, the Woods for Health strategy. And our drive has been basically to create new health-promoting opportunities in our woods and forests to help improve the health and life expectancy of Scotland's people, and to reduce inequality. And one of the challenges, I would say, that what I see in terms of forest bathing and forest therapy is that a lot of educated middle-class people are benefiting and enjoying that. But there's a lot of people who live in poverty and deprivation are not accessing or enjoying that. And how can we make it more accessible for everyone in our society so that we all benefit? And part of this has underpinned our Woods for Health strategy, how we target the people who stand to benefit the most. And one example of this programme, in terms of a flagship Woods for Health programme, is a programme called Branching Out. Now, Branching Out is conservation and green space on referral. And it's an ecotherapy programme, and it's specifically for adults living with mental health problems. So this is for adults who have mild and moderate anxiety and depression, and also for inpatients in psychiatric hospitals who have severe and enduring mental health problems. And a lot of the research would actually show that the people with the most severe mental health problems stand to benefit the most. So I won't cover the content in the slide, you can see that for yourself. It's an immersive experience, groups of 12, it's fun and easy, and it's led by a combination of health and environment professionals. So this is a combination of community psychiatric nurses, occupational therapists, working with foresters and outdoor leaders, and health rangers. So again, this is a collaboration. It's not about over-medicalising it. I think we have to be cautious about saying it has to be medical doctors who do this. Medical doctors are very expensive, and it's far cheaper to use a combination of professionals to deliver this. Well, the activities, what does branching out consist of? It consists of activities that appeal to all ages, both male and female, and it's patient-centred. It's really looking at you as an individual, and it's using traditional crafts, it's using photography and environmental art, it's using ecological surveys, bushcraft. Now, the programme's been a real success for us. It's delivered nearly in all of Scotland, apart from the islands. We have 22 delivery partners, NGOs, charities, as well as our own staff. We have over 300 graduates per year. It's won 5 public health awards back home in Scotland, and it's been developed jointly with the National Health Service. So we have a whole series of training programmes which are jointly endorsed and jointly badged. So you have to have a minimum of 2 years' experience as an outdoor leader. You have to have mental health first aid training. You have to have experience of therapeutic delivery. So we have a certified training course that we run with the health professionals. Now, moving on to the results of this study, we want to look at the programme outcomes. And this looks at the cost effectiveness. Now, I think it's important just to look at this area for a little bit and to talk about the National Institute of Clinical Excellence. This uses cost effectiveness analysis to consider the effectiveness of each drug on a case-by-case basis. And QALYs is a gold standard in terms of health economics. And we use this basically then to decide whether a drug or a treatment is cost effective in the UK. This is the standard measure that the medical professionals use to decide, is a treatment cost effective? And we've applied this to these natural experiments, these programs. I'm not sure if you've done something likewise, but this is working with health economists. And what we found with the NICE guidelines is that there's a threshold. If the program can improve your quality of life over a 6-month period, and it's below a threshold of £20,000, then it's deemed to be cost effective. So in the NHS, or the National Health Service in the UK, this is how we decide what drugs we will support and what drugs we won't support. And we've done 2 research studies on branching out. And what we did find is that there's an extremely high completion and retention rate, which is very unusual. It's between 70 and 80%. And the adults with the most severe and enduring mental health problems, they're the ones who benefit the most. And I think also that the cost effectiveness is about 17,300. Now, an antidepressant drug prescription for Prozac is about 14,000. So that gives you a comparison. This is a cheap, effective intervention, and it's not a drug. It's a natural intervention, and it doesn't have dangerous side effects. So I think it's something that we should be thinking about, is how do we make this more standardized treatment options? When you see a health professional or a mental health team, community mental health team, do they offer you forest therapy? Do they offer you branching out as part of your treatment option? Or do they reach for the prescription pad and prescribe you an antidepressant or another drug? What's the first thing that they consider? And we need to change that so that forest therapy and nature green prescriptions becomes part of the health professional or the clinician's menu of options that they can prescribe for people. Now, the focus groups we did on this showed that there was a strong areas of improvement in mental well-being, in physical health, in daily structure and routine, and in transferable skills and acquisition. But more importantly, for a lot of people living with mental health problems, they isolate themselves. They stop talking to members of the community, their neighbours, and they become isolated. This programme is about using nature to help people reconnect with people and feel comfortable again about being part of a community. So the future aspirations for the Branching Out programme, it's been running for over 10 years. We want to mainstream this green prescription into healthcare practice and make it business as normal. So it's not seen as a nice to have, this is seen as part of the mainstream health service. This is one of the options that you get when you go to see a health professional if you have a mental health problem with anxiety or stress or depression. And we want to continue to expand it. But before I move on, one of the key challenges here is who pays for it? And how does it compare in costs? So this programme costs less than €50 per day per participant. For an inpatient, the cost is about £250 to £300 per day. And for a patient who visits as a day visitor to a mental health centre, it costs roughly about €150. So this is a cheap alternative. And I think it does provide you with a choice. So green prescriptions are becoming a valuable tool, and we need to try and make sure we mainstream this, and we have the evidence and the research to show that it's cost effective and that it works. So I'm going to move on now to the second part of the talk. The references are there if anyone's interested and want to look at the research papers. You can see those. Now, a major programme for Forestry Commission in Scotland, and we're now called Scottish Forestry. I should have said that at the start. So we are the state forest owners. We manage the forest, about 10% of Scotland, on behalf of the people. And one of our flagship programmes is Woods in and around towns. So this is an initiative to improve the quality of life in Scotland, and particularly in our urban and post-industrial areas, around our towns and our cities. And how can we provide access to new or regenerated woodland? And we strongly believe that most people who visit the countryside have a car or they have transport, but what if you don't have a car or you don't have transport? Where can you go on foot or by bike? And we really wanted to bring woodlands to where the people live and work, as opposed to trying to move people to where the nature reserves or the parks are. That's expensive, it costs transport, and it takes money to do that. And people are not going to be able to do that on a regular basis unless they have some disposable income. So this program was really about trying to improve the green space, the woodlands where people live and work. And the objectives were to bring urban woodlands into active management to benefit communities, to create new urban woodlands to benefit communities. So we looked at the maps and we tried to identify towns or cities where there was no woodlands, and we tried to identify these areas where we could create new woodlands so that these communities had a woodland on their doorstep. And we wanted to support programs and activities that would help people to use and enjoy their activities. It's not good enough to build the woodlands. We also have to provide a helping hand, facilitated access, and enable people to use the spaces. For lots of us, it's normal for us to use the woodlands and the green space. It's part of who we are. But for many people, they're disconnected with the green space and the woodlands, and they're not using them. So how do we connect the people who are not using them? How do we connect them? And that's partly about facilitated access and about programs that introduce them to these green spaces. So supporting programs and activities to help people enjoy and use their woods. Now, this was a €1 million research study over 5 years. This was a major piece of research for us. And you'll recognize some of the academics involved. Some of them are internationally recognized as leaders, Richard Mitchell and Professor Catherine Ward-Thompson. And we obviously had health economists involved within this research study. So again, using health-related quality of life, these health economic measurements, to try and show if this physical or this natural experiment was effective. So the Wyatt project involves an initial capital expenditure on environment improvements between about €10,000 up to €100,000, and thereafter it provides maintenance money to look after the spaces for between 5 to 10 years. So the projects, it has to be a population of at least 2,000 people within 1 kilometre of the woodland. So you can walk there or you can cycle there. That's the criteria that we use to describe what a woodlands in and around town site is. Now, why are we doing this? Why are we trying to bring woodlands close to where people live and work? Well, we've heard about how many of us are stressed and anxious, how modern life is more and more challenging. And where do we go to try and restore or to recover ourselves? We tend to visit green or blue space. And we know that this mental health issue is very common. 1 in 4 of us in this room will have a mental health issue at some point in our lives. Some of us may already have suffered one, and we may have recovered. Across Europe, it affects 83 million people. And in Scotland, this costs the health service a lot of money. This costs the health service the estimate here is about £10.7 billion per year. And that's nearly £2,000 per person. So could we use forests and woodlands to help prevent this and to make more people able to cope and resilient in terms of their mental health, to have more positive mental health? And what we wanted to do was to look at people living in the most deprived areas, the communities that have less access to transport or cars, and also they have the poor housing conditions. And we know that the people living in the most deprived areas are more likely to suffer depression or anxiety. So could Forestry Commission Scotland's Woods in and Around Towns programme, could it help improve community mental health? Now, we were very optimistic when we started this. We felt that woodlands could improve population level mental health. And probably a lot of us in this room would agree that, yeah, forests can improve population level mental health. Who would agree with me? Who would put their hand up and say, forests can improve population mental health? Okay, I'm glad. I'm really glad. I'm not alone. I'm not the only one who thinks this, okay? So this was a challenge. This was the premise of the research study, and we set ourselves the challenge of, well, how do we try and prove this, and how do we use a very scientific mixed method in terms of the research study to do that? So we eventually picked 6 sites in 2012. They were paired with control sites based on various socioeconomic and demographic data. And we also looked at communities that were eligible under the Wyatt criteria. So this means at least 50% of the woodland area had to be within 1 kilometre or 1.5 kilometre of an urban population of 2,000 people. And we expanded this definition just a little bit. And the woodlands had to have a minimum size of 4 hectares. And we also wanted to make sure that they had at least 40% canopy cover, 40% of the land or the green space was covered in trees. And this was a 5-year longitudinal study, and we were looking specifically at, did this intervention improve community level mental health? But we also looked at, did the project have an impact on improvements in moderate physical activity, walking activities, connectedness to nature, and social cohesion, connecting communities. And obviously you can see that this was potentially a large area of Scotland was eligible for this intervention. So this programme, the Woodlands in and Around Towns programme, the Forestry Commission in Scotland, or Scottish Forestry as we're now known, we've spent over £70 million on this project. So this is a significant investment to bring woodlands back into sustainable management where people live and work. And I think that's the right thing to do. Now, I'm going to pause us there just for a second and say the health service in Scotland spends over 13 billion euros per year treating illness. 13 billion euros. So this is small scale. 70 million is big for us. We work in the forestry sector. That's a lot of money. But compared to the health spend, it's very modest. And this is about population health, changing the outcomes of health for people. And it's less than £15 per person. So it gives you the scale of this, and the programme's been running for over 10 years. But because this was a research study, we had to have 3 controls and 3 pilot sites. So we weren't looking at the whole Wyatt programme in the round from start to finish. And we studied the effect of the Woods in and Around Towns programme on mental health in 3 Scottish communities after it had ran for 2 years. We also used connectedness to nature scales, social capital and cohesion questionnaires, and surveys. So we had quite a comprehensive mixed method research study running with us. This is some of the details. You can look this study up online. It's fully published by the National Institute of Health Research. And there is obviously a significant research paper behind this, so this is just a shorthand. Now, the Wyatt study findings, I was deflated when I first got the research studies back. I thought this was the silver bullet, the magic solution. But we have to be honest and say that we did not find that stress levels in the Wyatt intervention sites improved. They did not improve. Now, there has been real learning from this, and I think when we reflect on it, although it was a 5-year longitudinal research study, it was simply too brief. It wasn't long enough to measure change in behaviour and health that operate over a longer time scale. Now, what we did find was that behaviour change is hard. Natural infrastructure is necessary, but not sufficient enough to achieve contact with nature. If you build it, they do not all come straight away. Promotion does not override culture. Some people are disconnected from forests, and they don't use them. How do we reconnect the people who are disconnected and bring them back? And we also need to look at the other benefits. So I think the positive here is that this was a really low-cost intervention. It's preventative spend for health and well-being, and one that can be scaled up nationally. We found that there was significant improvements in physical activity. There was significant improvements for the people who visited in terms of connectedness to nature. They were more likely to come back and revisit the spaces. And also when you look at the health-related quality of life, I think there was some positive findings to show that why interventions have the potential to provide other benefits if it can be attributed to the interventions and considered of a significant magnitude. So it raised more questions. And we haven't stopped here. What we have done is we're doing a new study, and we're trying to look at the whole of the WIAT programme at a Scotland level, rather than looking at free controls and free intervention sites. And we're trying to do an evaluation of that £70 million programme. So I'm going to stop there and finish. I've spoken for long enough. You can catch me at the tea break if you have any questions.
I have to reconnect you with the time, sorry.
We've got some more time?
Yeah, no.
Yeah, that's time.
We have to come to an end. But speak. Yeah, okay, thanks.